Hello, everyone, and welcome to the very first video in our new educational lecture series from the Society for Perioperative Assessment and Quality Improvement, also known as SPAQI. My name is Dr. Saloni Maharaj, and I'm a board-certified internal medicine doctor specializing in perioperative medicine and surgical co-management at the Stanford University School of Medicine. I want to take a minute to introduce the mission of this educational series. Our goal is to deliver short, high-yield videos that help healthcare professionals stay current on best practices in perioperative medicine. These videos are meant to be practical and easy to use for teaching learners at all levels. With that in mind, let's jump into today's topic, a broad overview of the preoperative cardiac risk assessment. This is one of the most foundational skills in perioperative medicine. Whether you're managing patients in clinic or consulting preoperatively on the inpatient wards, being able to systematically assess cardiac risk is essential for guiding safe surgical care. In this video, we'll cover the key steps of the assessment based on the current guidelines. The key reference that this overview is based on is shown here. The last major update from the ACC and AHA on perioperative cardiovascular evaluation and management for non-cardiac surgery came out in 2014. So we were very excited to see a long-awaited new update released in September 2024. As you can see on this slide, this guideline was a collaborative effort involving multiple societies. But for the sake of simplicity, throughout this talk, we'll refer to them as the ACC-AHA guidelines. These updated recommendations reflect important shifts in how we approach risk stratification and testing, so it's a great time to revisit the fundamentals. First, there's a revised algorithm for systematic evaluation. It offers a clinically intuitive approach to preoperative clinical decision-making. Second, the guidelines now incorporate the concept of risk modifiers, factors that may not be captured by traditional scoring systems but can meaningfully impact perioperative risk. Third, there is an expanded role for cardiac biomarkers, including when and how to use them preoperatively and postoperatively for surveillance and decision-making. And finally, there's a strong emphasis on shared decision-making and multidisciplinary care, particularly for our high-risk patients. This reflects the growing recognition that optimal perioperative management is truly a team effort. We'll touch on each of these throughout the talk as we walk through the updated framework. Here's a bird's eye view of the full algorithm from the 2024 ACC-AHA guidelines. Let's break it down step by step. The first question to ask is whether your patient has any cardiovascular risk factors, disease, or symptoms. If not, you can proceed to surgery without any further workup or testing. But if they do have risk factors or symptoms, the next step is to assess the urgency of surgery. If surgery is emergent, think of something like a ruptured abdominal aortic aneurysm, then the priority is getting the patient to the operating room as quickly as possible. In these situations, there often isn't time for cardiac testing and usually won't change management anyway. If the patient is having a non-emergent surgery, meaning falling into these three categories, then your next step is to look at whether or not the patient has any acute cardiac conditions that need to be managed. I like to think of these as hard stops. These include things such as acute coronary syndrome, serious arrhythmias, or decompensated heart failure. If any of these are present, they need to be managed acutely before surgery. That might involve you, a cardiologist, or other specialists, and usually leads to a discussion about the timing of surgery or alternatives to surgery. Once you've ruled these conditions out or treated them successfully, the next step is to assess your patient's risk for major adverse cardiovascular events, or MACE, and you do that using a validated risk calculator. The guidelines don't specify which risk calculator to use, nor do they say that any one is superior. Interestingly, each calculator looks at slightly different patient variables, which means a high-risk condition could be missed depending on which tool you choose. Because of this, the new guidelines recommend also evaluating whether or not your patient has any risk modifiers. These are additional factors that could increase their perioperative cardiac risk beyond what the calculator shows, and they include things such as severe valve disease, severe pulmonary hypertension, elevated risk congenital heart disease, prior stent or CABG, recent stroke, the presence of a pacemaker or ICD, and frailty. If your patient has a low calculated risk and no risk modifiers, then they can safely proceed to surgery without any further cardiac workup. If your patient has an elevated calculated risk and no risk modifiers, you may consider obtaining an EKG and ensuring that your patient is on appropriate guideline-directed medical therapy before surgery. Regardless of your patient's calculated risk, if they have any risk modifiers present, then you should consider involving a specialist to determine if further optimization is needed. You would also consider obtaining an EKG, ordering an echocardiogram if indicated, and ensuring that your patient is on appropriate guideline-directed medical therapy before surgery. The next step is to assess your patient's functional capacity, which you can measure either using METs, metabolic equivalents, or the Duke Activity Status Index, also known as DASI. If your patient can perform activities greater than 4 METs or has a DASI score above 34, they are generally considered to have a good functional capacity and can proceed to surgery. If they don't meet these cutoffs, then you need to ask yourself the key question: will further cardiac testing actually impact my clinical decision making or change the patient's perioperative management? If further testing would not impact your decision making or perioperative care, then you can proceed to surgery or consider alternative treatment options. This decision is usually made through a multidisciplinary discussion with the surgeon. However, if further testing would influence your plan, you may consider using perioperative cardiac biomarkers such as a BNP, NT-proBNP, or troponin as part of your evaluation. If these biomarkers are normal, you can generally think that it's safe to proceed to surgery, but if they're abnormal, then further cardiac testing should be considered. At this point, you could consider an echo, a stress test, or a coronary CT. And if these show low risk findings, then you can proceed to surgery. However, if the results indicate high risk findings, this should prompt a multidisciplinary discussion with your surgeon and cardiologist to carefully evaluate the timing and safety of surgery. For this higher risk patient subset, the new guidelines recommend considering postoperative troponin monitoring to detect myocardial injury after non-cardiac surgery, also known as MINS. This helps identify patients who may need closer monitoring and management after surgery, both inpatient and even after discharge. So thank you. That was a broad overview of the preoperative cardiac risk assessment based on the latest guidelines. In our upcoming videos, we'll dive deeper into each of these important topics, including how to accurately assess functional capacity, when and how to decide on further cardiac testing, practical ways to apply cardiac biomarkers in your clinical practice, and understanding MINS and the roles of postoperative troponin monitoring. Thank you so much for watching our first video in our new perioperative medicine lecture series. If you found this overview helpful, please like and subscribe so you don't miss the upcoming videos where we'll explore each topic and each step of the algorithm in depth. Also, feel free to leave any questions or topics that you'd like us to cover in upcoming videos in the comments. We want this series to be as useful and relevant to you as possible. See you next time. Bye, everyone.